You might come to me, for example, asking for something. It might not fit in with my norms and values, but I can't put my norms and values onto you.
You look really good, and it's a really nice result. Patient just wasn't happy. So no matter what I did, patient was just not happy.
People with BDD are really struggling, are really suffering, and for some it can lead to self-harm and suicide. So it's important to be able to understand and recognise that.
Hello and welcome back to our podcast, The Aesthetic Edge, where we like to give you the edge of innovation when it comes to aesthetics. Today I have a really important topic to talk about, BDD, otherwise known as Body Dysmorphic Disorder. It's a serious issue that's often seen in the world of aesthetics, so it's important for you as a practitioner to learn how to identify and treat it. Today I have a very special guest, Claire Newman, known as the Queen of Dermomedical, who's graced us with our presence, and we're going to be talking about BDD and what we can do about it. Claire, thank you so much for joining me today. It's a pleasure having you.
Yeah, it's good to be here.
Why don't we start off by you giving us a little bit about your background?
So I'm a mental health nurse. I've been working in mental health for well over 20 years. I now do aesthetics full time. I left the NHS 6 years ago. My passion is sort of it's mental health, working with patients to help support them through the aesthetics journey, but also making sure I safeguard them in their mental health.
Okay, wonderful. So clearly very well versed in the world of mental health. You know what you're talking about. And Claire, obviously this discussion is about BDD. So can you give our listeners a little bit of a description as to what it is?
Yep, so body dysmorphic disorder is a severe and enduring mental illness. It affects 1 to 2% of the population. It can affect people to varying degrees. So for some people it could be quite mild and they can sort of carry on with everyday life. But for some people, it can really impact on relationships, friendships, going out in public. It's where they might be preoccupied with one or more flaws on their face, body, and it may be very slight or unnoticeable to others. It's characterised by they might have mirrors, they might carry mirrors with them, and they might be constantly checking their appearance, looking for reassurance. They might have sort of rituals and behaviours that they will carry out before they leave the house, which can take so long they might even miss the appointment that they need to go to or work, things like that.
Very interesting. So it's something that I often try to keep a lookout for whenever a patient walks through my door. And I know that I have some screening questions, so I can discover whether they might have BDD or not. 2 of them are, how often do you look in the mirror? Have you heard of this question before?
Yeah.
And the average is, do you know?
Well, do you know what? There's a sort of on the tick box. There's quite a selection there, and my concern with these tick boxes is that for some people they can look in the mirror quite a few times a day, but not have body dysmorphic disorder. So it's for everyone. I think it's different. It's quite a tough. I think it's quite a tough question.
I think it's more the duration of how they're looking. So, for example, I know that the average person looks in the mirror is probably for an hour a day, which sounds like a lot, especially when I first heard of it. I think being a male is not quite as much, but a female, when you're doing your hair, when you're doing your makeup, that equates to 1 hour quite easily. Whereas if you have a BDD patient who's constantly looking in the mirror, so these times can go up to 2 hours, 3 hours, 4 hours. And if a patient were to tick anything over an hour, I wouldn't necessarily diagnose them with BDD. That's why it's a screening question. It's not a diagnosis. I might think, okay, there's a slight increased chance there. The other thing I've seen, I'm not sure if you've seen in practice as well, is that if a patient's telling me that they have asymmetry or deficiency in their face, and they're saying, can you see this? And I can't see it. Being a practitioner, being someone who literally looks at faces for a living, if I can't see what this patient's seeing, then generally I think that there might be a degree of BDD. Have you seen that in your own clinic?
Yeah, I have seen that at my clinic with some patients where they've literally had the mirror, the lighting, angling themselves and saying, see, can you see what I'm looking at? And you can't see it, and then you need to explore what's going on for that person.
So my first question would be, let's say we have a patient who comes in, we're a bit worried that they might have BDD. What's your first step? What do you do first and foremost?
I use the screening tools as a guide for my consultation, and I rely very heavily on that consultation. So I understand motivations. Why is the patient in my clinic at this moment in time? What do they want to achieve? How does it impact them? And for some patients, I will treat if there is a genuine concern there. But I do like to look at the impact it has on them going out, being with people, because I think that, for me, that will tell me the severity. If there's literally nothing there, that I really can't see, then you can't treat them really, because you've got nothing to treat, and you might end up making them worse, and they're going to feel worse about themselves, or they might feel better for a couple of minutes or a day or so, and then they might focus on something else, and that focus could be more severe than it has been.
I think the other thing that I often see is that some patients, they're constantly looking at themselves, and they're constantly worrying about this particular feature. So they go to multiple different clinics. So if I hear a patient that has come into my clinic, but she's been to 8 clinics beforehand and she's been treated by all of them, I have to think, am I that good? Do I think that I'm that good that I'm going to be able to fix what all the other clinics haven't been able to? So I'm not sure if you've ever thought about that. If you look at their previous history, who they've seen before, and seeing whether you're actually going to be able to help this patient or not.
I always ask them, why have you come to me? Why haven't you gone back to the practitioner? And sometimes it's really difficult because you can't verify what they're saying. So they might say, I've moved location, or it's just too far, or I'm working more at home. And with one of my patients, she did say she had moved location, so how the one's too far. And you sort of, on reflection, I like to reflect on cases, and if we have someone complex, we do case studies, and it makes me question whether that was the truth or not. And you can't sort of go and start fact checking everyone before they come and see you. So.
And as a general rule of thumb, let's say you have a patient who's diagnosed bog standard BDD, and let's say they do have a relative deficiency that you could treat. Do you turn them away, or do you treat them?
So I think for me, with my experience and knowledge, I will treat people with mild to moderate BDD, but I put a tight treatment plan in place. I'm very clear, I'm very boundaried, and I make sure they've got capacity, that they fully understand what's going on.
Manage expectations,
and and I don't do too much. So my most recent lady was a lip filler. There was a need to treat, so we did treat her. She was concerned about her skin. There was absolutely nothing wrong with her skin. That's quite common. People with BDD, they will focus on their skin. And I agreed to treat her lips, but I wouldn't touch her skin. And she was happy with that.
Okay, all right, excellent. You raised an important thing there. You said mild to moderate. So talk me through the difference between mild, moderate and severe BDD.
So I think mild to moderate, patients can sort of carry on with activities of daily living. They can hold down jobs, education. They can go out with friends. Sometimes they might miss events or not go out. People with severe BDD, I would say, really struggle to leave the house, and it might be they might not even be able to make it into clinic. If they're having a really bad day, they might not be able to make it. They might be late for the appointment. I like to assess the impact it has on them, because that will give you, I know I said it earlier, but it will give you a real view of what's going on for them.
Okay, all right, interesting.
There's patients where it's ruined relationships, where they've actually sort of separated, divorced, because the impact it has on them, that constant reassurance, not being able to go out.
And I assume the prevalence of mild BDD is probably more than severe BDD. So you see more milds. Would you not treat a severe BDD at all?
Probably not. I mean, some of my patients are already under mental health services, so they're getting the support that they need. I do try and signpost people on to mental health services, to their GP. We offer to write to the GP, but it's difficult because if they've got capacity and they're not consenting and they're not at risk to themselves or to others, it's very difficult for us. We can only advise and turn away and just hope that they don't go somewhere else, or if they do, they're not treated.
Exactly. And obviously you're very experienced in the whole mental health space. You know how to treat these sort of patients. Would you advise a relatively new beginner, a medical practitioner, to treat someone who has even a mild form of BDD?
No, I think they'd need to do some training, get their confidence up in aesthetics and sort of understanding BDD, because it is very complex. It's not just about doing the questionnaire and the consultation, it's understanding what it means for that patient. You might come to me, for example, asking for something. It might not fit in with my norms and values, but I can't put my norms and values onto you. So I need to understand, you know, just trying to give an example, you know, it could be, like I said, it could be a cultural thing, it could be a generational thing, it could be something you've seen on social media. So it's about understanding what it means for that person.
So let's say that I'm a patient or I'm a practitioner and I have a patient coming in, I'm relatively new in the industry, and I decide to treat a patient with mild to moderate BDD. What are the dangers of doing so?
So it can really have a negative impact on a person's mental health. So we see research where they say aesthetic procedures can improve someone's mental health. It's not always the case, especially for someone with BDD. They might feel better for a day or so, but then they might start to fixate on something else, or that problem just worse. So it's really important to make sure the assessments are done correctly before deciding to treat. And I think tight treatment plans in collaboration with the patient are really essential.
Yeah, it's absolutely super important, because if you're not having the consultation with the patient, you're not actually addressing the concerns, then how can you possibly create a good treatment plan for them? So Claire, obviously you've, being our healthcare expert or mental health care expert, you've actually written a course on BDD. Can you tell us a little bit about what it entails? Okay,
so it's a one-day CPD accredited course, and we literally cover everything. So understanding body dysmorphic disorder, looking at body image, so understanding what it means for that person. We look at assessing mental state, doing mental state assessments, assessing for BDD. We look at supporting patients as well, signposting, and there's a section on sort of managing a suicidal patient, which might think a bit, it might seem not relevant, but actually it is really,
absolutely relevant.
Yeah, it is really important to look at the suicidal patient, and I have had several suicidal patients in my clinic. So people with BDD are really struggling, are really suffering, and for some it can lead to self-harm and suicide. So it's important to be able to understand and recognise that as well. So by doing sort of detailed assessments,
Do you know what? I feel like as medical professionals who do aesthetics, we sometimes forget about how important mental health is. And we're just constantly focusing on the physical aspect. We're focusing on the deficiency that a patient might have, the cleft lip, and how we treat it. But we often forget that we are first and foremost medical practitioners. We need to make sure that we are gatekeepers to our patients, to make sure that they don't cross the limit, they don't go too far, need to have too many treatments, and they're not taken advantage of as well. Because you and I know, Claire, that there's a lot of unscrupulous injectors out there who don't give a toss about patients' actual mental health. And for them, every patient they say no to is lost income. But we, being caring, empathic medical professionals, will always make sure that our patients are safe, and we will not continue with treatments if it's not appropriate. For those patients, so for those practitioners who do decide to move forward with the treatment when they really shouldn't, tell me why they shouldn't do that.
I think it's really important not to just treat for the sake of it, because it does have a negative impact on someone. Someone might come to your clinic thinking, I'll just have some treatments, it'll make me feel better about myself. Or they might have other mental illnesses where they don't necessarily have capacity. If we're not assessing their capacity properly and we're just going ahead with treatments, and it can make them feel worse. They might just want to keep having more and more treatments till they start to feel better, but they might not look better or feel better about themselves. And sort of going on to your point about sort of mental illness, so every year I audit all my patients. So on my medical screening,
very good practice.
I have I've split up all the mental illnesses, and a lot of my patients have depression, anxiety, in fact more so than BDD coming into my clinic. Now I don't know if this patient group avoid me because they know my mental health history, and then the people with other mental illnesses come and see me. I've had patients with schizoaffective disorder, bipolar affective disorder, so it's really important to have a good understanding of all mental illnesses and not just BDD as well, because it can have a real negative effect.
Interesting. So you've seen a whole host of patients with different mental health illnesses. Can you give us a case study where you felt like the fact that they saw you, a qualified healthcare practitioner with mental health background, has been of great value to a patient? Is there a particular case study that pops to mind and you think, wow, my expertise really helped me for this patient?
Yeah, so between me and my colleague, actually, because this patient saw both of us for slightly different things, so we work very closely together in the clinic, and she has a history of depression, a lot of stress is going on in her life, and during our consultations we talk about a lot of things. I'm very nosy when I ask people, because I think if you get to know the patient and what's going on for them, it can help you give them the right treatment. And she was sort of very tearful during the consultation, expressing suicidal ideation. She'd actually sort of made plans as well, what she was going to do, but there was that element of her not wanting to go through with it. So we contacted her GP urgently, did a referral, got her some mental health support. And what we do, we also, if we have anyone in clinic that we've got concerns about, even if they're not necessarily suicidal, we do follow them up. And that's probably from when I worked on the wards and we discharged people, we'd always follow them up. And yeah, she's doing really, really well at the moment. So yeah, she's got the help she needed.
Do you know what? We all have stories like this. So I remember this is when I first got started. And obviously, every time you get a patient when you first get started, it's a big thing. You're really happy because you're starting a business, and every patient that comes to you is worth his weight in gold. So I was really happy when this particular patient came to see me. It was when I was working in one of these corporation clinics. I won't name the name of it, but it was a place where patients didn't get the time that they needed. It was sort of 10 or 15 minutes for each patient, and that including consultation, treatment, follow-up, everything. So I already didn't have a lot of time with this patient. Now, this patient came in and she said that I have a really obvious hollow here. And like I said before, in terms of screening questions, I was looking for this hollow and I couldn't really see much. But I made the decision that she has generalized volume losses, which is not too bad. I'll treat the patient. So I treated the patient, and the patient undoubtedly looked better, not only by my eye, but we took before and afters as well. And I showed the patient that and showed her that, you look really good. It's a really nice result. The patient just wasn't happy. So no matter what I did, the patient was just not happy. And then I asked the patient to let it settle down, give it 2 weeks and see how it goes. But this patient was messaging me every single day, like, I'm really worried about this. I'm really worried about this. Please let me know what we can do. Let me dissolve it. And obviously dissolving is possible, but it's not the most straightforward thing to do. Often you can create more hollowness. So it shouldn't always be inject, dissolve. You've got to think about it carefully. So this patient still wasn't happy, and I even shared the case study with the patient's permission with some of my colleagues, and they all said, she looks fantastic. And this one treatment, I didn't actually net that much money for anyway, because it was in a clinic and I was getting a ridiculous percentage. But the amount of headache that it gave me, because I decided to move forward with this patient, even though I did have some red flag symptoms that I was worried about, actually ended up causing me way more dissatisfaction, way more worry than it would have if I simply said no. Now, when I have patients that I have red flags about, when I have patients that I'm worried about, that I don't have a good feeling about, if I wouldn't want to have a glass of wine with this patient, then I won't treat them. And it will save me so much headache in the long term. Do you often have that as well?
Yeah, it's much safer to do that. Yeah, I mean, I have patients that are unhappy if I do decline treatment, but I'm very open and honest with them, and I'll actually tell them why or express my concerns and try and work with them to look at what the issues are.
Yeah, I find a really good way to do this, and hopefully this is a good tip to all the practitioners out there. If you ever get a patient and you're not really sure, you don't want to do the treatment because you feel like it's not appropriate, a good way to say no is to put the blame on yourself. So I always say, I'm sorry, I just don't feel like I can deliver you the result that you're looking for. They will leave happy because they're like, at least this person is honest. They weren't able to deliver the result that they actually want, and therefore they leave as a happy person. Whereas if I say, you don't need it, it's fine, it's all in your head, I'm going to get a complaint, patient's never going to come back. The other thing I can potentially do is say, I don't feel like you need this particular treatment, but have you thought about this one? Those are the patients that often stay with me for the rest of their lives. They'll come in for lip filler, and I'll say, the lip filler does not work for this reason. It doesn't suit the vertebral proportions in their face. But if I suggest, oh, actually, have you thought about skin boosters? And the skin boosters then make them look significantly better, that patient trusts me for life. So you must get this all the time.
Yeah, I mean, I always like to educate the patients as well. So like what's going on in my head, I'll explain to them so they understand my thought process in coming to sort of a conclusion of a treatment plan. But I like to do it with them as well, because sometimes as well, patients might look at YouTube or Instagram and they come with these ideas and
showing you pictures of Kylie Jenner saying, maybe look like this.
And sometimes it's misinformation on social media that they're coming to you for things that aren't suitable for them. So assessing them, giving them a mirror, manipulating their face in front of the mirror so that they can see what's going on as well. So that's
really interesting. So Claire, you've been very, very gracious with us with your time. So I'm gonna let you go with just one final question. How do you think your course, the BDD course, will help shape the future of aesthetics?
I think it will make people safer in their practice. You're protecting patients, you're safeguarding them. And I think everyone should be having some kind of BDD training.
Everyone should have BDD training. Yes. Absolutely. So everyone should get booked in to Claire Newman's BDD course. Claire, thank you so much for being with us today. I really learnt a lot. It's a fascinating subject, and you're a credit to your patients because they're definitely safe in your hands. Guys, I hope that this has been of use to you guys. If you have any patients, if you yourself have seen any patients that may have had BDD and you think this is useful, then please do share it. Share it with your friends. Share it with your colleagues. Let's raise awareness of BDD so we can help our patients, and as Claire so eloquently put, so that we can safeguard them. Thank you so much for listening, and we cannot wait to have you back on the next episode.